Hello, this is part 1 of neurocognitive disorders. This part will consist of delirium presented by Rachel Rome, which is myself, followed by major or mild neurocognitive disorders due to Alzheimer's, presented by Kellen Barton, and then major or mild neurocognitive disorders due to traumatic brain injury, which will be presented by Jennifer Owen. So, to begin, I have a video clip here on what delirium is.
Hi, my name is Tracy van Beek and I'm the Inpatient Therapy Lead for the Royal Free London Hampstead site. Today I want to tell you a little bit about what delirium is. Delirium is an acute syndrome characterized by disturbed consciousness for patients, disturbance in their thinking or cognitive skills, and disturbance in their perceptual skills. This means how they process information coming in from the world into their senses. This can be an acute condition, and it often fluctuates during the day and from day to day.
Right, so that is a brief introduction on what delirium is. Generally, it's considered an onset of confusion, especially if one is ill physically. 50% of elderly people experience delirium in inpatient settings. That's one of the risk factors we'll talk about later is age. It requires immediate medical attention because there are 3 possible outcomes of delirium. Either the patient gets better, which does happen in most cases. The patient might suffer permanent brain damage due to that fact that this is often onset from a physical illness. And in some cases, the patient may die. So the diagnostic criteria surrounding delirium includes a disturbance in attention, anything from reduced ability to direct, focus, sustain, and shift attention, as well as awareness, which could include reduced orientation to the environment. The disturbance develops over a period of time, usually hours to a few days, represents a change from baseline attention and awareness, and tends to fluctuate in severity during the course of the day. As just mentioned, often it gets worse at nighttime. An additional disturbance in cognition is necessary, something like a memory deficit, disorientation, language, visuospatial ability, or perception. The disturbances in criteria A and C are not better explained by another pre-existing, established, or evolving neurocognitive disorder and do not occur in the context of a severely reduced level of arousal, such as a coma, which we'll talk about a little bit more. And there is evidence from the history, physical examination, or laboratory findings that the disturbance is a direct physiological consequence of another medical condition, substance intoxication or withdrawal, due to drug abuse or to a medication, or exposed to a toxin, or is due to multiple etiologies. So, as I just mentioned, there are a few things that could onset delirium. Substance intoxication is one of them, and criteria A and C, which are the disturbance in attention and awareness, and disturbance in cognition. So this will look like the typical intoxicated person, usually disorientation, obviously. And then it can also be due to substance withdrawal. I actually had a patient, I work in an inpatient detox facility. I had a patient with alcohol-induced delirium who was stating that she had bugs crawling on her skin and she was hearing whooshing in her ears and kind of hearing voices. There's also medication-induced delirium, which is criteria A and C arising as a side effect of a medication. And then there's also delirium due to another medical condition. There are 3 specifiers on top of the fact that it can be acute or persistent. There's also hyperactive specifiers, which include agitated and aggressive behaviors, incoherent speech, disorganized thoughts, delusions, hallucinations, and disorientation. And hypoactive specifiers would look like sluggish and drowsy behavior. They're going to be less reactive, sullen, withdrawn. So those are kind of two ends of one spectrum. And then oftentimes we'll see mixed level of activities. So both hyperactive and hypoactive symptoms are presented, and the patient will kind of flip back and forth between the two. So some diagnostic features that are notable is disturbance in attention and awareness, usually accompanied by a change in baseline cognition that cannot be better explained by a pre-existing or evolving neurocognitive disorder. As I had mentioned earlier, it's generally worse in the evening, probably due to lack of stimuli, and delirium often underlies another neurocognitive disorder. So if we think of consciousness as a continuum, on one end we have normal attention and arousal, which is how we behave every day. On the opposite end of that we have a coma, and delirium falls somewhere in the middle of those two. And if delirium goes untreated, it can actually result in a coma. Some associated features supporting the diagnosis. Pretty notable are disturbances in the sleep-wake cycle. So we'll see behaviors of somebody being very sleepy during the day, have a lot of difficulty falling asleep at night, a lot of nighttime agitation. Maybe they're, overly tired during the day. Just kind of opposite of what the normal cycle is, if you will. Some possible emotional disturbances can look like anxiety, fear, depression, irritability, anger, euphoria, and apathy. And these disturbed emotional states can kind of be observed through the behavioral manifestations of calling out, screaming, cursing, muttering, moaning, and making other various sounds. So overall, luckily, this is not all that common, 1 to 2% of the general population, but the numbers kind of skyrocket for individuals over the age of 85 at 14%. Oftentimes older individuals in emergency departments, so 10 to 30% with that statistic. 60% of people in nursing homes actually will experience delirium at some point, and 83% of people at the end of their lives experience some form of delirium. Some helpful ways to kind of go about this might be early recognition. So as I mentioned earlier, it's really important that if somebody's exhibiting symptoms of delirium that they're checked out immediately, because the earlier it's recognized, the shorter it becomes because the person can be treated for it. As I said, it can progress to stupor, coma, seizures, or death. And 40% of those who are diagnosed with delirium actually die within the year of the diagnosis. So it's a pretty serious event. So some risk and prognostic factors will include the environment. So if somebody is immobile, if they have a history of falling, if they have low levels of activity, and if they use drugs or medications with psychoactive components to them, these all increase risk for delirium. And genetic and physiological would include another neurocognitive disorder, some other medical condition. I know that AIDS is one that can also cause higher risk for delirium, and older individuals are much more susceptible. And some differential diagnoses. Psychotic disorders, bipolar, depressive disorders with psychotic features can easily be confused because both are characterized by vivid hallucinations or delusions and language disturbance. So being that these are the primary symptoms of both, it's important to kind of rule other features out. Acute stress disorder is another that can kind of show similar features, fear, anxiety, dissociative symptoms such as depersonalization. Malingering and factitious disorders can be easily confused, as well as other neurological disorders. So it's important to kind of disentangle the symptoms of delirium and dementia to determine which is more appropriate in diagnoses. And there are my references. Thank you.